Welcome, Professor Yazici.
Nice to be here, thank you.
So, what is Behcets syndrome?
Behcets syndrome is an inflammatory condition that affects many organs, principally the eye, the skin, the mucosal surfaces, that's the lining of the mouth, and the genital organs, and joints mainly. But then it can also affect the brain and large vessels of the body. In general, it is a rather benign condition. On the other hand, especially among the young and the male, and by young among people aged around 20-25, on occasions it can cause rather serious harm, and the blindness is one of the worst things that can happen in this condition.
As we know, Behcets syndrome is more common in certain parts of the world than others. Can you elaborate on that?
Yes. Behcets syndrome was originally described in Turkey, a Eastern European or Mid-Eastern country, if you will. And it's basically most common around the Mediterranean basin, then Pakistan, Iran, Pakistan, north of India, and continuing with Korea and Japan, and some parts of China. So one might say that the Silk Route is the geographic area where it is most commonly seen. On the other hand, it doesn't mean that Behcets syndrome is not seen at other parts of the world. It is, but much less commonly. Some part of this unique geographical distribution most probably has to do with genetics of Behcets syndrome, but the exact reason we do not know yet.
Interesting. What about the sex and the age distribution of the disease, and also are there any specific genetic associations?
Right. Behcets syndrome is seen but rare among children under age 16. Most common, the usual age of onset is around age 20-25, and then again, as people age, it becomes less common. It's seen with almost equal frequency among men and women. On the other hand, men, especially the young men, definitely have more severe disease. Let me give you an example for this. For example, if you are a 20-25-year-old man with Behcets, your chances of having eye disease is something in the order of 70%, whereas if you are a lady, 50 years old, then the same chance is probably around 10%, or maybe even less. So there is this peculiar age and sex distribution. Again, we do not know the cause. Now, one thing you might have noticed that I am the president of the Behcets International Society for Behcets Disease, but we keep talking about syndrome. Syndrome, as you know, is given to not a particular entity, disease condition with mostly known causative reasons, but it is a constellation of symptoms and signs that we call a syndrome. Now, we like to call it Behcets a syndrome rather than a disease because A, we do not know its cause, B, the only way we can identify this condition thus far is just by a mere constellation of symptoms and signs. And moreover, more recently, we are beginning to see that there are clusters of those symptoms and signs. For example, arthritis usually goes with what we call acne-like lesions, or the superficial vein thrombosis on the skin goes with deep vein thrombosis, which also goes with thrombosis of the, or clogging up of the big veins of the brain, the dual sinuses. So we are now seeing that there are disease clusters. So I think we are more justified probably calling this syndrome rather than a disease. But this is, basically an exercise in semantics. You have asked about the genetics of this. Very crudely, where I come from, Turkey, I think the place with the highest frequency of disease, if you have 10 patients with this condition, among those 10, one would be a first, second, or third degree relative with the same condition. Moreover, there is a certain tissue type, which we call HLA-B51, which is more common in the people with this syndrome. This was originally described in Japan, later confirmed by us in Turkey, and basically it is the closest genetic marker of it. But on the other hand, if we talk about numbers, for example, Turkish people that do not have Behcets carry this HLA type about 25% of the time, whereas those patients with Behcets carry it about 60% of the time. So it is, to be a carrier of HLA-B51 is neither a necessary nor a sufficient condition to have Behcets, but it has something to do with disease that will be probably discerned sometime.
And you also mentioned that Turkey has the highest frequency of Behcets syndrome patients. What is the frequency in Turkey? And
there have been several, I should say, rather reliable studies, and among those people aged 16 and over, for the adults, the frequency is about 1 in 250, which is a very high frequency, in fact. This is true for most parts of what we call Asia Minor, Anatolia. On the other hand, we do have, again, reliable data on the European part of Turkey, which we call Thrace. The frequency is much less. And again, we do not know the exact cause for this.
Very well. What would you say are the most common presenting symptoms and the most common problems that the patients have, and also what would you say are the most troubling and morbidity, mortality causing manifestations of Behcets?
Okay, the hallmark is, of course, the frequent oral ulcers, and which most of the time are not different than the canker sores that all of us get, but in Behcets they are more frequent in number. They are more frequent and more in number when one gets it. About close to 100%, maybe 96-97% of patients with Behcets do have oral ulceration, the canker sores. Another good 90% have genital ulcers, and these genital ulcers, rather peculiarly, are on the scrotum in the male. As such, they differ from the genital problems related to venereal disease, where, for example, on the glans or shaft of the penis. In the females, they are usually on the outer labia, and again rare in the cervix. There are skin problems. The most frequent skin problem is what we call the acne lesion, very similar to acne that people do get in adolescence mainly. And this acne is seen on the face and the backs and the front of the chest, where the common acne is also seen. But in Behcets patients, the same acne are seen on the arms and legs, and we do not know why this is. The second frequent type of skin lesion is the so-called erythema nodosum, or the nodular lesion, and these are red bumps, and if one looks at them, these nodular lesions more carefully, then they are almost equally divided between the superficial thrombophlebitis and the true erythromonodosum-like lesion, where the true erythromonodosum-like lesion is more common among the female, and the superficial thrombophlebitis is much more common among the males. Apart from those, the Behcets patients can get other forms of out skin lesions as well, like the so-called sweet syndrome, etc. About half of the patients get an arthritis, which is usually transient and non-deforming. It involves only a few joints. About good half of the patients, with differing frequency among the males and the females, get eye disease. The most probably important manifestation of Behcets as far as the harm that is done, and it is usually what we call a panuveitis, which involves all layers of the eye, and if left untreated can lead to blindness. It usually involves both eyes, and one very peculiar aspect of the eye disease, a manifestation of eye disease, if you will, is the so-called hypopyon, which is an intense inflammation in the front of the eye, in the anterior chamber, and you can see the sort of layering of pus by the naked eye. And this eye disease has what we call exacerbations and remissions, flares and quiet periods, but gradually there is scar formation and the eye loses its integrity as an organ, and blindness ensues again, as I said, if you don't treat that. A bothersome problem is the inflammation of the big vessels, mainly on the venous side, seen in about 1/4 of the patients. And also there are problems on the arterial tree, and among these the pulmonary artery aneurysms are very grave, and they usually present with hemoptysis, coughing of blood, and unless they are treated very promptly, they carry a very high mortality. Fortunately, with prompt recognition, these days we have been able to bring down the mortality due to pulmonary artery aneurysms as well. These aneurysms, like the other severe manifestations of Behcets, are most commonly seen among the young and the male. The last problem I want to talk about is the central nervous system problem. And central nervous system problem is seen about maybe 10% of the patients altogether. And it can be just a headache due to dural sinus thrombi, which is rather amenable to treatment. But then there is the other kind with involvement of the brain stem, which can have a relentless course.
As you know, we've about a year and a half ago started the Behcets syndrome center at NYU Hospital for Joint Diseases, and a lot of our patients that we see complain of headaches, and not the type that everybody gets, but relentless, ongoing, repeated headaches. And have you found headaches to be a big problem with Behcets, or has it been...
Right, and we have also written about this too. Now, there are several types of headache in Behcets, and the majority of headaches seen is rather of no consequence, and it might be due to sort of tension headache and that sort of thing. On the other hand, some of it is due to the, as I have said, the clogging up of the big veins, the dural sinuses of the brain, and that has to be seen by either a CAT scan or an MRI of the brain. Again, that's amenable to treatment with brief courses of high dose of cortisone steroids. It's treated very rapidly. And The one more thing that has to be underlined about the central nervous system involvement in Behcets is that those patients with the dural sinus thrombi mainly do not seem to get the other kind of, the brainstem kind of involvement, and the vice versa. Again, we do not know why this is so.
What about the prognosis of Behcets syndrome?
Okay, as I said in the beginning, and we have formally looked at this, we do have good solid data on what happens to Behcets patients in 20 years, and what we have found out is that a good portion of the patients, they do not, you would not recognize them as Behcets 20 years on. So these many people with just skin and mucosa manifestations or joint disease, the disease just wanes off. On the other hand, some of the patients with eye disease or patients with central nervous system disease or with pulmonary artery aneurysms, especially again if they are young and male, they might have a grave prognosis. In fact, in Turkey we have some specific numbers for those. If you are a patient with young male with Behcets, your life expectancy initially can be reduced. On the other hand, if let's say 10 years pass after diagnosis and nothing has happened to you, then there is a very good chance that nothing else will happen to you. And that is the cornerstone of our treatment. We want to treat the patients with big vessel disease or eye disease very early, as early as possible, with the best agents we have at hand. And if the initial few years pass without harm, then there is a very good chance that the body will heal itself. In this respect, let me add, Behcets is rather different from the so-called autoimmune diseases such as systemic lupus or rheumatoid arthritis, where there is an increased mortality, if you will, with the passage of time, and this is not so with Behcets. Yeah. Now, one reason for this and this is an area of active research we are doing right now, and that is that atherosclerosis might not be increased, probably not increase in Behcets to the degree that it is increased in patients with systemic lupus or in rheumatoid arthritis. We have looked at the calcification of the coronary arteries of our very severe patients with Behcets, who are, by the way, also smokers and had used steroid or cortisone and such. And even among those, the coronary calcification, a marker of coronary atherosclerosis, was not much increased. We recently have data which also show that the so-called atherosclerotic plaques among the Behcets patients are not increased in any degree compared to the age-matched healthy controls. So I think that is probably one of the reasons that the late prognosis of Behcets is rather good.
How about pregnancy and Behcets? Getting pregnant and during the pregnancy, does the disease have any effect on pregnancy, or does the pregnancy have any effect on the disease activity itself?
Okay, there is not much actually hard data on this, but we do have clinic of about 6,000 patients with Behcets, and our, let's say, informal experience and some informal experience reported by other centers suggests that pregnancy does not have much influence on Behcets and vice versa. And in this respect, actually, it also differs from the classical autoimmune diseases where pregnancy does have rather profound effects. And so we do not actually, unless the patient is using a drug which would be harmful in pregnancy, like cyclophosphamide, we don't recommend against pregnancy, and if the patient gets pregnant, then we try to modify our treatment accordingly.
Another frequent question that we get from our patients is about vaccinations.
No, there's no problem with vaccination in Behcets, and if the patient is using an immunosuppressive, of course the live vaccines are a problem, and they are not recommended, but otherwise, with the vaccines prepared by dead microorganisms, there's absolutely no problem.
Let's come to the treatment of Behcets syndrome. Mm-hmm. How do we treat various different manifestations of the disease?
What we basically do, as I said, that the young and the male get the most attention because they get the most severe disease, and we immediately start with anti-inflammatory, if you will, immunosuppressives in treating those patients. For example, a patient with eye disease in our clinic immediately is put on azathioprine, which we had shown years ago was rather beneficial in preventing many of the manifestations of Behcets, and also is put on cyclosporin A, which is a very rapidly acting agent. And with the combination of the two and brief courses of cortisone, we are able to control the eye manifestations and favorably affect the prognosis. In fact, over the last 30 years, the prognosis of eye disease has got better rather impressively due to those drugs. Now, there is a portion of our patients, maybe 15-20%, rather close to 15, that would not respond to this treatment. Then next step would be either to use interferon or go to do TNF-alpha blockers. Now, the TNF-alpha blockers are, of course, used in many inflammatory diseases today, and with Behcets, the experience is still rather limited. The only controlled experience had been with etanercept, and that was our study we had published. We had shown that a brief course, a 1-month course of etanercept, was clearly superior to not giving the drug in controlling the oral ulcers and many of the skin manifestations. Now, in what we called uncontrolled experience, infliximab seems to be rather effective for the control of eye disease, very rapid control of eye disease, but still the controlled studies are needed. There are other agents that are used. Thalidomide can be used for severe oral ulceration, which is rather successful, but of course thalidomide does have problems on its own, like the teratogenicity if used during pregnancy, and neurological problems. But sometimes we can get by very small doses of 50 milligrams a day, which we can help some of our more resistant patients.
A lot of our diseases, rheumatologic diseases, most patients use steroids for some time at least, and some patients need to use it chronically. What's the role of steroids in the treatment of Behcets?
Okay. Now, very recently we have published on the use of low-dose steroids in a controlled study, and what we have shown was that small doses of cortisone injection did not do anything for the oral ulcers or many of the skin manifestations apart from erythromonodosum. Now, the larger doses of steroids are still used, and we use them too, in control of inflammation in the big vessel walls and also in the control of eye disease, but again we use them only for very brief periods of time. Now, as for colchicine, we have more data which basically show actually colchicine is not also good for many of the manifestations of Behcets. Unfortunately, it is the most widely used drug in Behcets, but again, lacking scientific support. I think the only indication to use colchicine in Behcets is those patients with erythema nodosum or arthritis, and maybe the genital ulcers among the females. So I think it's in our clinic, our specialized clinic, we limit the use of colchicine to those conditions.
There is also a controversy about how to treat the deep vein thrombosis and the thrombophlebitis that's seen in Behcets syndrome patients. Can you talk about that a little?
Right. Well, there are two conditions, two systems, treatment of two systems in Behcets. We do not have good control studies available. One is the treatment of central nervous system, and the other is what you just mentioned, the thrombophlebitis. Now, we do not anticoagulate our patients with Behcets who have thrombophlebitis for the simple reason is that we think, and there are data to support this, that the main problem is not a problem in the coagulation cascade, but is inflammation in the vessel wall. Now, if you take a segment of a patient with thrombophlebitis with Behcets, as we had done in the past, mainly in the post-mortem specimens, you see that the whole segments, large segments of the vein are inflamed, and the thrombus that is formed is very sticky to the vessel wall, and this is much unlike to the old garden variety thrombophlebitis. So what we do is that we treat those patients with anti-inflammatory immunosuppressives like azathioprine or interferon or maybe TNF-alpha blockers. TNF-alpha blockers, there's debate about that because in certain situations they might be causing thrombosis as well. But certainly do not use anticoagulation. Sometimes you might use antiplatelet agents, but again, this is just on a, not evidence-based actually. So we do not use heparin or oral anticoagulants in our clinic in treating the thrombophlebitis in Behcets.
Lastly, what are some current lines of research that you're interested in and other centers are interested in patients with Behcets syndrome?
Well, let me start with what we are doing. We have done, actually, our center has done many of the controlled drug trials in Behcets, and currently we are going on with that. We are now doing a double-blind study of oral interferon in Behcets, and I think in about 2 years' time or so we will have a formal answer to that. And we are also planning studies on formal studies on thrombophlebitis in Behcets. There is currently in England going on a blind study of systemic interferon in Behcets, but again it will take a couple of years. We are preparing protocols to use anti-TNF agents in Behcets, but they have not started yet. Another active line of research we are pursuing is to look at atherosclerosis in Behcets, and I said, we have initial data to show that atherosclerosis is not increased, but we want to widen this. Another area of research we are interested in is to look at more closely at clusters of disease expression we talked about, and we are trying to define those more, and we think this might have importance in trying to enlighten the pathogenesis of this condition. Now, our colleagues around the globe are also looking at the genetic associations of Behcets, and available data right now indicate that it is a true complex disease with many genetic associations. Recently, Behcets has been classified among the so-called autoinflammatory conditions with the more recent interest in mechanisms of inflammation. There is active research going on on how inflammation comes about in Behcets. These are the main streams of research around the globe.
Thank you very much. This was very helpful, and I think it will be very helpful to our physicians and patients also. Any closing comments before we leave?
Well, I think in brief, we know much more about this condition than we did 30 years ago, and we can do much more about this condition than we could do 30 years ago. But two main areas are still problematic, and that is the control of the central nervous system disease and death of thrombosis.
Well, thank you very much. It was a pleasure having you.
Thank you.